Good morning, everyone. My name is Olivia Henze from New England QIN-QIO, and I'll be your moderator for today's webinar, ONC's 10-Year Vision for Connected Health. The New England Quality Innovation Network Quality Improvement Organization works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives to improve patient safety, engage patients and families, and improve clinical care at the community level. Thank you for joining us for today's webinar. Before we get started, just a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar, and the phone lines will be on mute for the duration of the presentation. We'll take questions through our chat box on your screen at the end of the presentation. Feel free to pose a question throughout the presentation itself. However, we will not be addressing any questions until the end. At this time, I'd like to introduce today's speaker, DeStefano from the New England QIN-QIO. John has extensive experience with state and federal level healthcare reform initiatives and has over 20 years leading interface development and web services implementations, including development of an emerging health information exchange in a multi-hospital environment. John's past positions include being a CTO of a state health information exchange and director of interoperability at a large IDN. Please welcome John. John?
Thank you, Olivia. Great. So why don't we get started? So today we're going to discuss ONC's 10-year vision for connected health. And so our disclaimer for all of our presentations. So moving along, objectives for today's discussion. So as I mentioned, we're going to discuss ONC's 10-year vision for connected health. This is a document that was published in October 2015, version 1 of it. It had numerous versions before that. But if you're really interested in reading the document, it's kind of long, but you can certainly go to the links that I'll provide shortly to find those the documents that we're going to be talking about. So the objectives for today are to talk about what a learning health system is. One of the primary focuses of the ONC's vision is for the nation to develop a learning health system. So we'll talk about what a learning health system might look like. I'll also provide an overview of our progress to date on this roadmap. The roadmap actually started in 2014, even though it wasn't really published. Version 1 of it wasn't really published until 2015. We'll also identify expected changes between now and 2024, which would be the 10-year anniversary of the roadmap. And I'll also go into a little bit of detail around how the current CMS payment reform initiatives and the roadmap initiatives either merge together or don't. I mean, it's really up to the listeners to decide. I have a problem with that myself to really figure out whether they do actually coincide exactly. So these are the two documents we'll be talking about. Now, I have a certain perspective on this, and we all have perspectives on different things that we read based on our past experience. So, as Olivia mentioned in the beginning, my experience is really not as much with policy, although lately more on policy, but really my experience really focuses on technology. So I look at this roadmap maybe from the eyes of somebody who has implemented large-scale technology at the state and local levels. I hope it doesn't skew my view too much. So before we get started, I think we need to define a couple things. And these, the few things that we'll talk about are definitions that are also in the roadmap document. So what is interoperability? Again, I mentioned earlier that my view of interoperability is more from a technical perspective. But that's very narrow when it comes to developing a nationwide roadmap for interoperability and to change the way we practice healthcare in this country. So the ability of a system to exchange electronic health information is one aspect of it. But you can see here in the first bullet that we also need to take into account the users of the system. So all participants in an interoperable system should be able to transparently use the system to exchange data. And that just doesn't include hospitals or providers even, but it also includes patients and people who want to exchange data. So individuals, families, and healthcare providers in an interoperable system can send, receive, and find electronic health data. Currently with the mandates and meaningful use, we definitely have send and receive as part of certified electronic health records. But the find part has eluded us somewhat. Many health information exchanges around the country have the ability to query for data, but it's not as widespread as it needs to be. Also, interoperability needs to deliver the right information to all the participants at the right time. So this includes individuals and caregivers who are active collaborators in healthcare. So a provider and a patient or a person should be able to easily connect data and collaborate on healthcare. So to continue on with the interoperability definition, what are some of the features of an interoperable system? You can see here critical public health functions, including real-time case reporting, disease surveillance, and disaster response. This is ongoing work at the federal level to be able to collect data and respond quickly to disasters and disease. We don't really have it. We don't really have that capability developed to the extent that it needs to be. Data aggregation for research. So if we're going to drive change in the system, one of the really important parts of it, which we'll go into in much more detail later, is the use of data. We have lots of data in healthcare, but it's very difficult to aggregate it at the kinds of scale that needs to be aggregated at to really influence population health. And interoperability needs to also be able to support administrative and clinical data. And again, this goes probably with that idea of aggregating big data to be able to drive value-based payment systems. So another definition, stakeholders. And you'll notice the use of people in all of the books. Much of the healthcare literature today, when we talk about, we formally talked about patients, we really don't see that term being used as much anymore. We're all patients in the system at one time or another. So, the ONC documents and documents from the federal government now really, when the term patient has in many cases been replaced by people. So who are the stakeholders in this system? So people who receive care, certainly. So that would include consumers, patients, caregivers, family members who may be assisting someone with their care, and organizations that represent these stakeholders. How about organizations that deliver care? So that would include such things as hospitals, pharmacies, ambulatory providers, laboratories, and home and community-based services. There's also a governmental aspect there, so the federal, state, tribal, and local governments. People who organize or organizations that generate new knowledge, so researchers, public health researchers. So other types of or other stakeholders in this system. So organizations that provide health IT. These guys are frankly a very important part of this revolution that needs to take place to get to a learning health system, and those are the technology providers. So those companies that provide EHRs and other health IT assets, and that goes beyond your traditional EHR vendors now to new innovators who are developing mobile applications and wearable applications for patients to monitor their health, or people to monitor their health. There's also the certification and governance stakeholders who provide certification and the certification and governance capabilities to the system. So those organizations that certify EHRs would be an example there. And standards organizations. So HL7 is I bring that out as an example of a standards organization. They are certainly a stakeholder in this and are driving or assisting in helping move the system forward through standards. So what's a learning health system? This is very interesting. There's a link at the bottom to www.learninghealth.org. Very interesting site if you haven't seen it before. And it goes into what makes up a learning health system. So certainly one thing is timely and actionable knowledge. And what does that mean? That means putting the right data in the right place at the right time to affect care. And it is truly one of the key ingredients of a learning health system. Learning large is an interesting concept. So we have a problem with data in this country and the way we use it. We have millions and millions of records about with patient data in it, but we don't really use that data systematically and routinely like we could to affect population health. So one of the aspects of a learning health system is to be able to use data at scale to actually affect patient care. So ongoing cycles of knowledge generation is another aspect of a learning health system. So how do we utilize data? How do we take data and draw lessons learned from it to change and create a system that learns in cycles? All stakeholders participate in a learning health system, so it's not just about caregivers or hospitals or laboratories. It's about the people who are actually receiving care. Everybody needs to be coordinated and in sync with each other to really have a learning health system. One of the other aspects of it is the health IT aspect of it. So a learning health system is built on top of meaningful use and other health IT investments that are already currently in place. So we don't start over to build a learning health system. We already have a foundation in place. And the foundation that's in place will hopefully shorten the care delivery, will shorten this gap in care delivery. So currently, there's approximately a 17-year gap between knowledge that's generated and when it's actually applied. So the current systems in place, we aggregate data, we examine it, we research it, and then before it finally actually gets back into the system, it's 17 years. So a learning health system doesn't have that kind of gap in it. It has a much smaller gap in it, where data is being analyzed real time and decisions around population health and different programs that might be implemented to affect population health happen at a much quicker pace. Let's talk about the 10-year vision. The 10-year vision includes the following bullets here. So interoperable health IT ecosystem. So back to that idea of the right data at the right time in the right place. And IT products and services that allow healthcare systems to continuously learn. So the utilization of big data is key to this ONC vision for a learning health system. A learning health system that facilitates lower cost of care and improved population health, another part of the 10-year vision. And support for critical public health functions. So, again, back to that idea of real-time disease surveillance, data aggregation, a changeover to value-based payments that reward quality versus quantity. What are some of the guiding principles that were defined in the roadmap? So, focus on value is certainly one of the guiding principles. We talk a lot about value, quality, quantity, about the U.S.'s position in the world around where it ranks as far as quality of care and outcomes. So, we've all heard about the large percentage of our GDP that goes to healthcare, and the fact that we're one of the most expensive healthcare systems in the country, in the world, if not the most expensive system. In fact, we are the best in the world at taking care of sick patients. There's nobody who does it better than the United States. Many individuals from other countries who can afford it will come to the United States for sick care. So if you have cancer, if you have some chronic disease, if you have a disease that may benefit from advanced technology, much of that care that we provide in this country is the best care that you can get in the world. So we're very good at taking care of sick patients. What we're not good at doing is taking care of our population when it's well and maintaining well care. So that cycles back and feeds back into the sick care system, which makes our system very expensive. So a future focus on value is one of the guiding principles that the roadmap was developed on. Also be person-centered. We have a great resource in this country from a healthcare perspective that we don't utilize very much, and that's the patient. The patient knows a lot about their healthcare, has a lot of data about their healthcare, and we don't utilize it very well. So one of the guiding principles is really to involve the person in their own healthcare. Protect privacy and security goes without saying. If we can't develop a system that's secure, patients won't use it, people won't use it, and it will be of no value. And we need to build a culture of electronic access and use. We're seeing that more and more consumers using wearable devices. The industry around mobile applications that are healthcare related is getting quite big. Between now and 2019, it's expected to be over $2 billion. So to develop that culture of electronic access and use, the healthcare IT system or the healthcare system needs to meet people where they are, and that many times is in a mobile way. So allow patients, people, access to their data through mobile devices. Build upon the existing IT infrastructure. So we need to not just throw out what we have, which has taken, frankly, years to build. We need to leverage it. So we have, I believe, a good foundation in place to be able to move IT or the interoperability of healthcare data forward, and we just need to leverage better what we have in place. So one size does not fit all. What does this really mean? It really means that there needs to be a baseline of interoperability, and we see that some of this with meaningful use. So in meaningful use, there's a baseline to be able to send and receive data, and it's mostly based on direct messaging. So that is the baseline. Now, others who have more, either more sophisticated or have more, or have different potential uses and ways they want to use data, may develop systems on top of that that are much more elaborate and much more functional with different use cases. So we still need to have that baseline so everybody can participate at least at some level. But there are more sophisticated, potentially, organizations who will develop more sophisticated ways to use data and move data. So it needs to be simple where it can. And a good example of this, again, is direct messaging that certified EHR technology needs to have. So that's a relatively simple protocol that's been in use for many years in different forms. It's not as complicated as query-based exchanges that some health information exchanges would provide. So in many cases, we need just simple ways to get things started. Maintain modularity is again, another interesting concept. So large systems are more resilient to change when they can be connected together as opposed to big hierarchical systems. So you can think of a learning health system in this country, say the federal government decided to just put one in place, one huge monolithic hierarchical system. That wouldn't be as palatable to change as smaller components that are wired together through standard interoperability methodologies. So modularity is very important. We need to maintain that going forward. We need to also consider the current environment and support multiple levels of advancement. So not every provider will get to the same place at the same time. Some providers, as I said, will have the capabilities and the access to very sophisticated technology, may move at a much faster pace than providers who are in rural areas who don't really have the real need to exchange a lot of data. So we're all probably going to get there at a different time, and we need to consider that as one of the guiding principles in the roadmap. Empower individuals, which we've talked about, and leverage the market. So demand for health IT will be a powerful driver. As consumers want to have access to their healthcare data, that will be a powerful driver. And so we need to leverage the market going forward. So what are the highlights from the plan? The plan is really broken up into milestones. So there are three big milestones in the plan, and they're at different, or they take into account different periods. So the first of these is a 3-year plan from 2015 to 2017. And the hope there is that every provider will be able to send, receive and find healthcare information. So what do we need to do to get there? We need to scale our existing approaches. So we have in place right now EHRs that are capable of using direct messages. We have emerging health information exchanges in various parts of the country. So the plan between now and 2017 is to scale up what we have. Another big part of this first 3-year plan is to work on the vocabulary and standardization. So by the end of 2017, we should have good vocabulary so that systems exchanging data understand what that data is, and we should have good standards in place so that vendors who are building interoperable technology will all be using those same standards to interoperate data. And the 6-year plan, use information to improve quality and lower cost. So the major parts of the plan between 2018 and 2020 are to enhance interoperability, so building on the vocabularies and standardizations from the first 3 years, be able to aggregate and trend data, and come up with new methods to measure quality. So the third part of the roadmap between 2021 and 2024 is the real development and enhancement of the learning health system. So what are some of the features of that? One of some of the important milestones there. We need to have a connected health system, again, built on what's come before, the previous 2 large milestones. Part of what we should see in a learning health system is that we have active individual health management. So we see people managing their own health, having the ability to use maybe mobile technology or better ways to communicate with their provider to manage their own health. So a system that's moving from sick care to well care. We'll have even more evolution of standards and policies to be able to support this kind of a system, and the large-scale use of data for analytics. So the fundamental building blocks here to get to the learning health system. Certain things need to be put in place. So core technical standards and functions. These are things like patient matching in the system. Should be doing patient matching the same way so we can identify patients across healthcare organizations. We'll see the emergence of directories, so healthcare directory white pages to be able to find providers across the country. If say one provider wants to send a message to another provider who's on the other side of the country, you should be able to look up an address or a way to send that provider information through a directory. We're also going to see, or we also need to move standards forward around authorization and authentication. So how we decide what a particular provider is authorized to see. Again, some of you who may have been involved in or are involved in data interchange know this is a really big issue. And we also need to be able to identify users within the system. So if we think of a national healthcare system where interoperability is prevalent and providers can't just reach out to find patient data when they need it, we need to know how to authorize those providers from a security perspective. We also need to, another one of the core building blocks would be certification to support adoption and optimization. We have a lot of activity going on right now around certification. There's certification of our electronic health record systems. There are various other bodies, which we'll talk about in just a couple of slides, who are involved in certification. So that process is well underway, I think, from a fundamental building block perspective. Privacy and security. We still have many security changes. Anybody who, reads the internet news, listens to the news on TV, reads the papers, know about cyber threats now, and that could really slow down the journey, the road to a learning health system if we don't find ways to protect our networks and our data. So a supportive business, clinical, and cultural environment. And this really focuses on that change to a value-based system. So from a building block perspective, we're really talking about policy levers here. So CMS being willing to pull those policy levers, which in fact with the emerging new value-based payment systems, we've seen that in fact they are willing to pull those policy levers. And rules of engagement and governance, there are various organizations right now that have been set up to, mostly by the ONC, to provide governance for stakeholders for participation in various, mostly technology projects. So governance organizations like Direct Trust, which is an organization that governs the direct health information service provider marketplace. And ONC has set up additional organizations to help provide that governance structure. So there are certain critical pathways that need to be focused on, and the roadmap identifies a few of those, I think. So improved technical standards, which we just talked about, that change to value-based payment, and part of the roadmap here is to make that change to value-based payment very quickly. I think anybody who's examined the MACRA Act would agree that it's a very aggressive and fast change from a fee-for-service system to a value-based system. Privacy alignment. From the perspective of those doing interoperability right now, privacy is really not aligned. So there is no real direction, let's say, from the federal government. Many states have different privacy rules when it comes to healthcare data. There are even organizations that have their own privacy rules in place. So in an environment like a fragmented environment like that, it'd be very difficult to decide or to move private data and get that data to only those individuals who should have access to it. So there definitely needs to be some clarification there, and it probably needs to come from the federal level initially to get that process started. Now, the stakeholder alignment is also key here, one of the key pathways that we need to focus on, and that's going to be very difficult. As I mentioned earlier, there are many, many stakeholders in this environment, and to get them all headed in the right direction, I use the analogy of herding cats. It's going to be a very difficult challenge. So on to the specifics of the roadmap. It's a pretty large document, pretty dense reading. It has 3 sections in it, really, and that define some of the components of the roadmap, and those sections are the drivers, the policy and technical components, and then the expected outcomes. If you want to count the call to action section, which is an appendix at the end, which is, again, very large, you could also do that. So you can see here in this little graphic the transition, how each of those sections would affect each other. So drivers would drive or help assist policy and technical components that need to be put in place to finally get to the desired outcomes. And I'm not going to talk in detail about the policy and technical components, but I am going to talk a little bit more in detail about the drivers. So the roadmap, as we said earlier, is broken up into these larger aggregated milestone sections that are based on years. And as I said also earlier, the appendix, I think, is worth looking at. It's not, to just want to examine it, just to look at the size of it and the number of calls to action that are in it. Again, I think it's a very aggressive time frame, 10 years, to be able to bring about this kind of transition. And there are hundreds of calls to action. So I'm just, as somebody who's been involved in this part of the healthcare industry for a while, I just wonder how that number of calls to action is going to be coordinated at the scale that it needs to be coordinated to realize a learning health system. So let's talk about one of the primary drivers here, and I think this driver really is key to the roadmap's vision, and that's a supported payment and regulatory environment. Currently, we have a shift that we're undergoing from an environment that is based on fee-for-service to one that's based on value. The Medicare, Medicaid EHR incentive program is a primary motivator. We've seen that. We wouldn't have the number of interoperable EHRs in place if it wasn't for the EHR incentive program. So, CMS has demonstrated that they can affect the environment when it comes to interoperability in a large way by this particular incentive program. Now, one of the things, though, that as we're all aware of in the current environment is that business isn't adequately rewarded right now. Isn't adequately rewarded since it's a fee-for-service rather than a value-based system. To even want to include a lot of electronic health information exchange in the workflow. We hear again and again that data is power, so organizations that have large amounts of data aren't necessarily all that interested currently because there really aren't a lot of incentives to share that data. And history has shown that without the right financial incentives in place, systems and technology components are built and not used. And I can vouch for this from my experience at the state health information exchange level. There's a lot of spend done through the ARA funding to stand up health information exchanges in each state. The problem was that it was, I think, a little bit before its time, financial incentives to make organizations want to connect to it and exchange data that just wasn't there. And so many of those health information exchanges ended up not being successful. So interoperability can be a significant tool in a value-based system. And this is really evident when you consider how providers in the future, how their reimbursement will be calculated. So in the future, providers are going to be more and more accountable for patient outcomes and total cost of care, regardless of where else an individual receives care. So if I'm a primary care provider and a particular patient is attributed to me, and he receives care in a hospital, I'm still responsible for that patient and their care. So in situations like that, exchange of healthcare information between providers and organizations is going to be critical to the provider's success. So we do, as mentioned earlier, need systems in place, models that reward quality over quantity. And I think that'll be driven by the business case of the provider, where they really need to have that information in place in order to be able to take good care of their patients and keep them well and out of expensive situations. So just to talk a little bit about payment reform, since it's such a critical part of the roadmap. Many of you are probably familiar with MACRA, the Medicare Access and Chip Reauthorization Act. It has three components, so merit-based incentive payment system, alternative payment models, and physician-focused payment models. In a very short time, 2 years or so, physicians who see Medicare patients will be under the MACRA Act. So many of them will be in the merit-based incentive payment systems, although I do believe in the future we're going to see a lot of alternate payment models developing too. So under these kinds of situations, providers are going to need to use certified health IT as part of the model. Not only will they have to use it in order to effectively run their business, but it's also part of what's going to be required as part of MACRA. So health IT provisions in MACRA will, in fact, reinforce that link. I have a slide in a moment which will demonstrate that providers really do need to use EHR certified technology, in fact, as part of the scorecard for MIPS. Now, another thing that we're going to see going forward with this program is that a lot of providers who weren't involved in the Meaningful Use program or weren't eligible will still be paid under the MIPS or MACRA program. So we'll see a lot more providers adopting electronic health records who in the past weren't incentivized to do that. So why why don't providers right now choose to share their data? And it really goes back to that idea of there aren't really the business drivers in place currently, although with change in the payment system, there certainly will be very soon. So many providers have concerns around the liability of exchanging data. This is, probably very well founded because we don't, from a federal level, we have HIPAA, but we don't really have a good or a very structured system to define what liability is and risk around exchanging data. We have HIPAA, which certainly puts a lot of emphasis on safe exchange of data, but from a technical perspective, how do you implement HIPAA, and how do you make providers feel comfortable that the data exchange that they're doing is limited from the liability perspective? Many providers lack trading partners. So, especially in rural areas where providers may be pretty far spread out, they don't have trading partners. So, there really isn't a need for them to trade information with trading partners. There's also that idea of competition, that data is a powerful thing, and that if you have data, you can in some way affect the market in your favor. So that idea of competition, again, comes into it. And there's also the difficulties in switching EHR vendors. So some providers who might want to exchange data just don't have systems that they feel are, from maybe a workflow perspective, are easy enough to use. And switching technologies, as everyone knows, is a very difficult thing to do. So the next slide here, I just wanted to point out the progression in the MIPS program around eligible professionals. So you can see in the first 2 years, really, eligible professionals that we're used to seeing, most of them in the Meaningful Use program. But going forward, you can see the large number of additional professionals that will be part of this program and reimbursed under MIPS. So this program is really aimed at the entire marketplace and not just a sector of it. Getting back to how health IT is a critical part of MIPS, you can see the reimbursement scale here. Now, these numbers may have changed since I put this slide together, but you can certainly see Meaningful Use of certified health information technology is 25% of the score. Quality, maybe PQRS reporting right now, the way PQRS reporting done is another 30% of the score. So that, again, utilizes electronic health IT. So health IT is a critical part of the MIPS program going forward. And just to give you an idea of the timeline, many of you have probably already seen this slide, but the MIPS or MACRA program, specifically MIPS, it's really a winners and losers program. The program has to be budget neutral. So there'll be an average score nationally that will set the bar, and if you're below that score, then you're going to be subject to a payment adjustment in the negative direction. If you're above that score, you'll be subject to a payment adjustment in the positive direction. And you can see that the program really starts kicking in. You can see the incentives start kicking in, or disincentives start kicking in 2019. That is, the 2019 reimbursement or disbursement will be based on 2017 data. So we're very close to this new payment model being put into place. And some of the drivers here for this first part, the milestones for the supportive payment regulatory environment. You can see that by CMS, by 2018, or in the 2018 to 2020 time period, CMS will administer 50% of all Medicare payments to providers through alternative payment models. So that's pretty interesting. I think that it seems that CMS feels that there'll be a lot of evolving and emerging alternative payment models. Another interesting thing is that by 2018, CMS would like 90% of care paid for by CMS to be tied to quality. So we see definitely a movement towards quality as opposed to fee for service. Okay, so as I said, we talked a little bit more about the driver of this roadmap, then we're going to talk about the individual policy and technical components. But I'll just go quickly through these next few slides just to mention a few important details, I think. So shared decision-making and rules of engagement. Where are we right now with that? Well, we have various organizations in place, some set up by ONC, that are providing policy and technical or providing rules of engagement for all the stakeholders. So organizations like the Commonwealth Alliance, who some of you may have heard of, the Sequoia Project, which was formerly known as Healthy Way, was actually funded by the ONC to provide some governance for query-based exchange. Direct Trust, another organization that provides governance around direct messaging, and again, they were given some money from the ONC to do that. So those policy and technical components, from a policy and technical component perspective and decision, shared decision making, the idea of all the stakeholders participating. There are various organizations in place currently to be able to support that. So ubiquitous and secure network, well, cyber threats are rampant. We have seen them, especially recently, targeted at very large retailers, like I'm sure everyone is familiar with Target and the issues they had around cyber attacks. There are a number of other large retailers. We see it all the time right now in the marketplace. The thing that's happening right now, though, is those retailers are getting a lot better at securing their IT environment. So moving along from I guess, a hacker's perspective, we're starting to see attacks on hospitals. So ransomware attacks on hospitals. There have been a few notable cases that have come out. When it's easy, a hacker will actually try to attack the easiest target. So as some of the larger retailers patch up their environments, I think we're going to see more attacks on healthcare organizations. Now, hospitals have the capabilities to secure their systems to a much greater extent. So over time, I'm sure that those kinds of things will happen. But I'm sure once that happens, it probably won't be uncommon in the future to potentially see attacks on maybe private practices, so physician offices. So this is a real concern and continues to be a concern. And so from a policy and technical component perspective, we need to continue to develop ways to move data that's both safe and protected. The verifiable identity and authentication of all participants is, again, important. We have a very fragmented system currently to be able to do that. So going forward, the roadmap outlines a number of steps and call to actions that will need to take place to be able to authenticate participants across the entire healthcare ecosystem when it comes to moving data. Consistent representation of authorization to access electronic health information, again, it's very fragmented. Organizations that support health information exchanges have local ways to do that, but to do it at a national level where patients may want to access their data from a state other than what they live in when they're on vacation or something like that, needs a lot of work. And so, again, there are a number of calls to action in the roadmap document to address that. The consistent understanding of information and the permission to collect, again, goes back to that idea that we need some guidance from the federal government around that. So there are federal, state, and organizational systems or representations of data, provision in various systems to be able to collect data. Every hospital has a consent form to collect data. Health information exchanges have different ways to collect data. Some may be opt-in, some opt-out. So there isn't really any federal guidance. It's right now, again, very fragmented system. Industry-wide testing and certification we're doing pretty well with. As I said, there are a number of certification organizations in place. So IAG Connect-a-thons are one that comes to mind, where vendors who implement the IAG protocol can go to test their implementations with one another. ENAC is an organization which does direct trust certification, and there are also the EHR incentive program certifications for EHRs. The consistent data semantics goes back to really, currently it's an HL7 thing mostly. So we have HL7v2, we have the Consolidated Clinical Data Architecture, and now FHIR emerging as semantic ways to move to represent data or concepts in the healthcare domain. We'll see a lot more work, I think, going forward on those. But we do have at least standards in place right now, and they're widely used by the vendors, so that's a good starting point. Again, consistent data formats. We are, again, in a pretty good place with that. Those formats need to be non-proprietary, and I think that that's evolving. So we have formats around HL7 and that type of thing that newer HL7 standards are, in fact, open source and non-proprietary. So we're making progress there. Secure and standard services, this goes back to that concept about healthcare APIs. So is there a way that from a healthcare perspective that we can have common APIs that all systems will use to interoperate data, not only the larger healthcare IT vendors, but also smaller, maybe innovators who are building applications for mobile or building applications on mobile platforms. So the larger players in the marketplace, the EHR vendors, health information exchanges, have those types of standard APIs in place, but they're very complicated, and so innovators have a very difficult time with them. So I think we're going to see more emergence of simpler healthcare APIs, probably based on the FHIR HL7 standard. That'll help with this and allow innovators to be part of the market and thus pick up a lot of person or patient use. Secure and consistent transport techniques we've talked about. Accurate and individual data matching is another big one. Many systems have electronic master patient indexes technology, which they use to uniquely identify a patient across the number of, say, hospitals. The problem with that is that they're localized to, say, a health information exchange environment. So when one health information exchange wants to talk to another health information exchange, they don't necessarily do the matching exactly the same. So this is a problem. There have been certain provisions put in place at the federal level, actually, to develop a national identifier. The problem with that is, even though those things were put into law, they've never been funded, due mainly to political reasons, and it doesn't look like in the near future they will be funded. So we need to figure out how we identify patients across not just a single hospital, but across multiple hospitals and even across a region as large as a state or a larger region in the country, say, like the New England region. Data directories, we have a few in place right now. We see some states standing up provider directories that you can go to and find information out about a provider. There are some at the federal level also. One that comes to mind is the SureScripts physician directory. Many physicians use SureScripts for electronic prescription processing, and that's a very, very large network which you can go and look up providers across the country. So we're going to see a lot more directories. Why do we need directories? Well, if I want to use direct messaging in Connecticut to send a message to somebody in California, I need a way to look up that California provider's secure address so I can send it to them, and that's where registries play a key role. So roadmap, the final section of the roadmap are the outcomes. So what would we expect the outcomes to be from the application of the driver that we talked about in the beginning and all the policy and technical components? Well, we'd expect that individuals have access to their longitudinal medical data, and that they can also contribute back. So that's again, a goal which involves both technology, workflow, and opinion, frankly, from the provider perspective. So a lot of components to that. We'll also hope to see provider workflows that transparently include the sharing of patient information without having to think about it. So there are EHRs right now which certainly can, as we mentioned earlier, use direct messaging, but it's usually, the workflow usually involves somebody actually making that happen, pushing a button in the EHR. In the future, that should all be transparent. Data should just move transparently. We also, one of the outcomes also would be tracking and progress and measuring success. So one of the outcomes of this, of course, is that continuous quality improvement feedback loop where we have goals, we measure success, and we make changes in order to improve on those goals. So from a more visual perspective, we're just going to go over this real quickly since we're running short on time. But the ONC also put out a document here. It's very visual, and I think it's a good way to look at the journey to better health. The link for it is on the bottom of the page. So the first part of the document, or graphic here, defines the goals by 2017. So that's the majority of providers who send, receive, and find electronic health information. Challenges here, HIEs are not standardized, the way we exchange is not standardized, we don't have the right authentication and authorization systems in place. The payment models really aren't aligned with it, so the incentives to exchange data between providers and patients really isn't there yet. It's emerging. And the privacy laws, as I said, are inconsistent. There are privacy laws at the state, federal, and even organizational rules in place, so it's very fragmented. And there's a general lack of trust within the environment. So that's where we are right now. There have been some gains. You can see 78% of physicians are using electronic health records. There's been a number of gains around building that baseline capability in order to leverage and expand on. So by 2020, what we expect to see is definitely an expanded set of stakeholders. So there'll be more. We want to engage more stakeholders in the exchange of data, and that really, again, is going to focus a lot on the patient from the patient perspective. So we want to involve patients to a much greater extent in their own health care. And there'll be greater information sharing with public health. So there are many reporting systems right now in place for public health. In the future, as data starts to move transparently in large quantities, we're going to see much more public health data available to do research on to change the system in the appropriate way. And then finally, by 2024, we have this learning health system in place. And so again, we'll see more stakeholders involved in it, and you can see that we're in our happy place now where we have happy people and smarter spending and better care. So some key takeaways from this. One of the things that we've heard again and again, and is evident if you read the roadmap document, is really this idea of getting patients involved in their own health, and that being a facilitator to better health. Higher quality based on really a change in the payment model that we have right now, so pay for quality as opposed to quantity. More efficiencies that can be gained through health information technology and the ability to exchange data easily and transparently between providers and patients. Innovative payment reform, not only what we're seeing now as far as a shift from quantity to quality, but also as we start to gather more data, even more innovative payment models, maybe based on APMs or emerging APMs, that type of thing. And another thing that's not on the slide is certainly more vendor competition. So the more demand in the marketplace for, say, consumer-based apps around health IT, the more vendor competition, and that'll drive technology and innovation in technology even further. So I'll stop here. I know I apologize for going kind of fast at the end. We're running out of time. But if you want to type any questions that you have into the chat, box, and please send it to all participants. I'd be happy to answer it at this time.
Thanks, John.
So I see a question about the slides in the presentation. Yes, it's available on our on the QIN-QIO website under the Events tab, and I believe it's available right now, Olivia. Is that correct?
Yes, that is correct. It should be available now. When you received your JS details email, it was in there, and we will be sending a thank you email as well tomorrow, so you will get it again. But I can include that link right now for everybody.
I don't see any questions. I just have maybe one more comment because we have a few minutes. We talked a little bit about healthcare API. So a way for healthcare systems to easily be able to exchange data between systems and thus move data or put data in the hands of the stakeholders. So there is. I encourage everybody to go out and take a look at the HL7 website and look for FHIR, F-H-I-R. It's an emerging standard, HL7 standard. It's based on the same kinds of technologies that we use right now to build web-based applications, which are all over the place right now. So what it does, I think, is invite a lot more potential innovators to the party, as opposed to the way we interoperate healthcare data right now, which tends to be very complex based on IHE standards, which are kind of complex and web and heavy web service type technologies. FHIR is a very different approach, based, as I said, based on the way the web works right now. So I think as that becomes more prevalent, we're going to see a lot more innovators in the market, and that will really help from the perspective of engaging patients, because patients will have a lot more smart technology in their hand, where they can not only aggregate or gather data about themselves and their own activities, but they'll have the ability to send it to their providers. So I think it'll be interesting how FHIR evolves over the next few years. Okay, Olivia, I don't see any questions in the chat. So again, thank you for bearing with me for the last hour. And I appreciate everyone's participation. Thank you.
Thanks, John. I just have a few more last-minute announcements before we end the call today. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing the computer with someone else, you'll receive an email tomorrow morning with the link to the evaluation, as well as the link to the event page on our website, which is also in the chat box. The PowerPoint presentation is posted there. Within the next few days, a recording and transcript of this webinar will also be added. And thank you all for attending. Thank you again to John, and I hope everyone has a fantastic day.